they both intertwine with one another. And it's conceivable that working with them with direct voice rehabilitation, moving the focus of their voice up, certainly might affect them in a positive manner, so to allow them to close their larynx with less force.
Yes, it does.
What I'm saying is that there are patients that, despite the fact of dealing with their stress, dealing with their psychological anxiety, changing the focus, they still may not have a very successful result. Conversely, there are patients that, despite giving them the toxin, despite giving them surgical correction, may not have a very good result.
I would argue with that position. I would agree with it. But I'm saying that patients don't know that they're misusing the voice and think it's some outside force. I'm saying it's not an outside force, and it is basically the focus of voice being from down here. I would agree with your assessment. It's always down there. It is, and you can't use the word never always. You're told that. In this case, it is always in the lower throat. The squeeze is always in the lower throat.
Right, I'll agree with that. Sure.
And the breathing is often misused. It is reverse breathing. It is lack of breathing. They don't have any midsection support. The normal person, you or I, and you do too, has midsection air support. But the individual with spastic dysphonia or a voice problem often reverses it or has a poor midsection air support, so they're squeezing from the lower throat. And what I do is I change the voice up here with a very simple procedure. It's so simple that patients who've recovered over the years have said the same thing. The litany is it's too simple to believe, yet it works.
I'm always surprised that patients that develop spastic dysphonia develop it in a very short period of time.
You can develop it overnight.
Overnight, just about. And that's kind of a medical conundrum, because it's hard to explain why somebody can be talking normally one day and the very following day have a very...
No, I would say that depression can bring the voice down, psychological and emotional concern, anxiety. Any kind of tension goes into the lower throat. That's the barometer. And another factor is, I would say, not only can it occur overnight, the majority of cases I've seen of spastic dysphonia over a 30-year period are gradual onset. They're not overnight, but there are the overnight cases. And they have misuse of the speaking voice. They want a lower pitched voice. They want a certain type of voice. They want to push their voice from the lower throat. They let tension, pressure, and anxiety push the voice down there.
I think it's hard to decide what comes first, the chicken or the egg. And they may even come both at the same time. Clearly, patients that develop voice problems have a tremendous amount of psychological overlay. They have difficulty with their job, talking on the telephone, relationships with their family and friends, communicating. And so there's a large functional overlay that's set on top of any problem, whether it be a physiologic abnormality, a neurologic problem, and it's hard to separate them because they all become part of the same problem.
Which is the first and which is the end. I would say that if you change, and we have found this, if you change the mechanical pattern, I'm saying spastic dysphonia is a mechanical pattern per se. Mechanical pattern per se. If you change it from the lower throat and have the breathing and put the voice up here, you can then decrease and eliminate the emotional, psychological attribute. Now, there are patients who are psychological in nature who have the will to talk down there or don't want to talk. They're in a very small minority. But the vast majority don't know they're talking in the lower throat and don't know emotional and psychological pressures, so put the voice down there and need to get a voice lift, voice up here, and then when you change the voice, the emotional and psychological pressures disappear and they're off and running. It's an interesting area. And it's fascinating because these patients have recovered. A Dr. Don Dotson was at Stanford University. He was told basically it's hopeless, and he came down here from the San Francisco area some years ago and recovered his voice. I worked with him on direct voice rehab, and he was interviewed in the LA Times with Beverly Bayette. He still has an excellent voice as his years after therapy. This is true of Reverend James Johnson.
Now, those are clearly people, though, that had the type of a disorder that could be treated effectively by your techniques. I think there are other patients, and I think you would have to admit that probably have other problems associated with it that aren't going to be amenable just to direct voice rehabilitation.
Gerald Burke, you're absolutely right. I am not saying that direct voice rehabilitation is the panacea for all. And the reason for that is that there are a number of people who want magic now. They believe in surgery, they believe in botulism, they believe in the magic. And direct voice rehab may take time. Some patients take longer, some take shorter. Reverend James Johnson came from the Mayo Clinic. He was a patient there, and he had the problem for 9 years. Couldn't talk, and he didn't want surgery. He came from Illinois, came out here, stayed with me for 1 month, and recovered his voice. He worked intensively, and he's never had the problem in 3 years. He's asymptomatic. And the Mayo Clinic, I understand, has closed the case saying he's totally recovered. It took 1 month. Now, I've done it in 3 months, in 6 months, in a year, in 2 years, in 3 years. I've done it in 4 weeks. So the issue is the patient, the cooperation of the patient with me. Whereas in surgery and botulism, you don't need any cooperation. You just impose an invasive procedure. If it works, it's fine. And if it doesn't, then they have to seek elsewhere.
Right, but that's true of any form of therapy.
Yeah. We've been talking about spastic dysphonia and the aspects that fascinate us in that field, because it's considered such a mysterious element, and I don't find it such. I find it to be a very simple problem.
Oh, I agree.
Easy to diagnose, in a number of cases easy to help, and other cases more difficult because of the variables.
Right.
You've been doing surgery involving ishiki, Nobuhiki ishiki.
Right, we've been doing framework surgery at UCLA for the past several years, and rather than just inject Teflon into patients that have glottal insufficiency, there are other newer techniques to correct patients that have weak and breathy voices, and we've been very pleased at some of the results that we've
You're using a substance in there, some kind of splint.
No, actually I use autogenous material. I just use cartilage to move over. I don't particularly like to use elastic, which is like plastic.
Why are you doing the surgical procedure on these patients?
These are patients that frequently have had vocal cord paralyses due to a number of different causes, or may have vocal cord weakness, again a paresis due to a number of different causes, and come to see us and have very soft, breathy voices. And on examination, after we send them through our complex voice evaluation, we come to the determination that they might be helped by this procedure, and a large percentage of them do very well.
I worked with an individual, Rick Roman, who had an injection, had a paralyzed cord, and it didn't take, or the voice didn't come back, and I worked with him and helped him get his voice back. And I've done that with a gentleman, Dr. Ralph Conker, who's joined me on this program. He had a recurrent laryngeal nerve severed. We got his voice back by direct voice rehab. Again, there's a divergence of views. You can do it by the surgical procedure. If it works, that's fine. You can do it without surgery, and you can do it by direct voice rehab. And I've been reporting success by direct voice rehab for years and years.
Well, certainly there are patients with vocal cord injury that learn to compensate. That is to say, the normal cord learns to come across midline and afford closure.
That's what we're doing.
Right, that's exactly what you're doing. I think any patient should undergo some voice therapy because they're going to have problems swallowing, they're going to have problems with weak voices, and they need to learn to strengthen the cord that's left. But even above and beyond that, all the voice therapy in the world is not going to return some voices back to normal. I had a lady that could sing with a vocal cord paralysis, and so I had a beautiful voice, and you couldn't tell. But the vast majority of patients have very weak voices and are breathy and require some additional augmentation.
I would not argue with the position. I would say that given the opportunity, it can't hurt them to have direct voice rehab, and if it's successful, they don't have to have a procedure. If they have a procedure and it doesn't work, they can have voice therapy, direct voice rehab, because it can work in combo. The same is true botulinum for spastic. If it doesn't work, don't give up. Do something about it. You might find success by direct voice rehab. If you had a surgical procedure and it hasn't taken, don't give up. Don't feel your case is hopeless. I've been talking with Dr. Gerald Burke. He's at the UCLA School of Medicine, head and neck division. We're now doing some studies there. Should prove interesting. Divergent points of views on voices. Yes, thank you very much, Gerald Burke. I'm Mort Cooper. The title of the program, Change Your Voice, Change Your Life. If your voice is up there and it's down here, you don't like what it is, don't just sit there. Do something about it. Join me next week, same time. Good night.